So it's really great to be here with you today. So thanks to Greg for the invite. It's always good to see Leif and Raphael. We kind of known one another for years and have worked together consistently during that time. It's a good time. So it's never a good time to get myeloma, but if you're ever going to get it, I think now's a good time to have it because it's not all doom and gloom. I'm older than these two, but I don't look it, of course. But when I first started practicing, if you have myeloma, it was awful. So bony disease that kind of eroded your skeleton. People shrunk, lost 6 to 10 inches in height. Their kind of rib cages came to rest on top of their pelvis. People were racked with pain, and the outpatient clinic was an awful, depressing place to be. And it's worth saying that because when you see your kind of compatriots who also have myeloma, you notice that none of those things are the case anymore. And so not only have we made progress in stopping those devastating consequences of the disease, we're also started talking about cure. And kind of people are hesitant to talk about cure. And I was going to avoid it. But I think that picture that Raphael showed was very, very informative, where you saw the curves coming down as sort of people were lost. But when it got to 10 years, the curves looked flatter. So you weren't losing people so much anymore. And a definition of cure that you can use is getting to 10 years and having the same potential survival as 100 of your colleagues or compatriots who didn't have myeloma and having the same survival. So you can think of it as functional cure, the cure fraction, but there is a cure fraction of myeloma. And I think what Raphael's slide showed was that cure fraction can be as high as 50%. So not everybody's going to get that, but looking at 10 years is now where you should look for outcomes, not at 2 years. People, you read the literature and it says you've got 2.5 years to live, and after that time, your disease is going to be in a bad position and things aren't going to go well for you. But that's not the case anymore. Oops. So, and this is why. So these are a set of treatments that have become regularly available over the last 15 years, starting with bortezomib and the 2 IMiD drugs. And we've been really lucky over this kind of 15-year period to regularly have new drugs that work better than the ones we had before with different mechanisms of action. And so I'm British, I'm not Scottish, praise the Lord. However, it's really important to say that we can be a little depressive as a group of people. And so I thought in this latter stages of my career that we just go round and round, use the same drugs, kind of nothing would change. But you can see on the end there that there's been huge changes in understandings in just the last 2 years, where the ability to use the immune system, either using antibodies, bispecific antibodies, or CAR T cells, really does work. And the way to tell you why it's better. So in the worst type of myeloma patient, this great new drug, daratumumab, had an 18% response rate. In a similar study with CAR T cells, the response rate was 80%. So when that moves from that setting to the upfront setting, we're going to have a whole new set of treatments and subtypes of treatment that are really going to move us forward. And the next slide tells you something about where we are and where we need to go. So Leif talked about transplantation up front, and as did Raphael, and I think both are right. But this is the disease paradigm we've been working on, which is presentation, treat, response, relapse, response, relapse, treatment doesn't work, death. And that's a very, very sad story and a very sad disease paradigm. And what I'm arguing for is that we develop strategies to get as many people the best survival up front as we can and change to this paradigm where you treat the disease with your best weapons in the first instance, then maintain the response for as long as you can, and then keep your fingers crossed that the cure fraction at 10 years goes up consistently. And so I kind of changed my slides rapidly to take account of the excellent description that the two boys produced for you around subclonal, intraclonal variation in myeloma. And this sort of aims to show that variation within the clone and takes you back to Charles Darwin and how finches adapt to their environment in the Galapagos Islands. So it's similar for the cancer cells. They adapt, and there are multiple different subtastes, as it were. Your treatment has to take account of all of those different subclones, because if you leave one, that's the one that can lead to relapse. And so I think they both did a good job of explaining what our current treatment approach is. So I think you can express it as sort of bags of sugar in a way. So when you present as a myeloma patient, if you have 30 to 60% cancer cells in the bone marrow, that equates to 1 to 2 bags of sugar, just sitting in your bone marrow, messing with your body. And so you have to have a treatment that reduces the level of that bulk until you go down to maybe 1 grain or 2 grains. And that's the analogy of minimal residual disease. Reduce the big lump of tumor to something that you can barely detect. And the way we would do that is by induction treatment. They're all the same types of treatment, but you just separate it into what you use to control the disease. Then you try and consolidate those responses, get any last cells. You can do that before and after transplant, and then control the disease long-term with some type of maintenance therapy. And so, again, there's a polar bear metaphor there. So you have lots of polar bears to start with, and you want to reduce those polar bears down to nothing or very few. I think the point made about damaging patients with treatment is very, very well made. So you want a doctor that understands this, but a doctor that you can talk to and explain your symptoms, the problems you're having. You should never damage a patient with your treatment. And so that's a very important message. But nonetheless, the tools we have allow us to take this strategy, which we couldn't a few years ago. But as we've sort of shown with this intraclonal heterogeneity, if you do a scan, if you're always taking a sample from your iliac crest, you could have a pretty big tumor up here and you might miss it. And so combining minimal residual disease testing with imaging takes account of these multiple icebergs of disease. So can attaining MRD negativity be equated to a cure? Probably not yet, but it's a good indicator of a good long-term outcome, and it's one of the early things you can measure in the clinic to give patients reassurance that they're responding well to the treatment. So what's the basic problem we have now? So I kind of like these kind of hexagons, or yeah, hexagons. It tells you the basic problem. So the last 5 years have seen us gone from single agents to using 2 drugs to now using 3 drugs. And so 3 drugs is the standard. You could go to 4 drugs. I think it's important to take account of what Leif said about the financial implications of this. However, I think our job is to do our very best for patients. And so you can take cytotoxic drugs, chemo drugs, you can use the IMiD drugs, you have a second-line group of drugs there, including pomalidomide and daratumumab. There's a new oral bortezomib available called ixazomib. And down the bottom, you can see that we still haven't explored the use of the CAR T cells, bispecific antibodies, and the cell mods, a new type of thalidomide-type drug that is more active but different. It's been traditional, and I think will still go on, to separate patients broadly into people who are fit enough to have a stem cell transplant and pursue the transplant option from patients that really it poses too much of a danger to in terms of their health and long-term outcomes, that you would want to not go that way. But here are some examples of combinations, and the size of the column shows the extent of response rates that they achieve. And you can see broadly that as you go from 1, 2 to 3 drugs, that the size of the column is higher and you're getting better responses. And so while RVD may be the standard treatment these days, I think within the very near future that daratumumab is going to be added into that, and we can expect even greater responses. So this is just an example of one of those survival curves that you now understand how to interpret. But on the top, you can see the curve titled RVD, and that is clearly lies above. And if you lay above a curve, the patients are doing better. So RVD in a randomized trial is doing better than RD. So 3 drugs better than 2 drugs, possibly 4 drugs is better than 3 drugs. But you can't pursue that logic to its ultimate. So you have to design triplets or quadruplets that have different mechanisms of action that you can pick from the toolbox to give to patients. And I think this makes the point about what you're trying to do with treatment. So upfront, you want to reduce the level of the cancer cells. You want to kill cancer cells. You can accept some toxicity in your patients. But long term, you can't accept toxicity. You have to have good quality of life, and you have to be able to get back into the community, go back to your jobs and do things. So in the long term, you want to use the immune system to control the disease to prevent relapse. And this is just a mechanism based to show there's more than one way the immune system works. And if you see this for daratumumab, and I told you the comparator between daratumumab and CAR Ts, you can see that there's a huge difference in the outcome of RD, Revlimid and Dex, when you add a monoclonal antibody into it that targets the tumor cell. Elotuzumab, another antibody, perhaps a little easier for patients to take, which directly stimulates the immune system, and people are exploring stimulating the immune system in the context of lenalidomide, Revlimid, long-term maintenance. And this is to show that there's a variety of targets on the surface of the cancer cell, and the one that everybody's interested in is called BCMA, and it makes not a jot of difference what its name is, but that's what the antibodies are targeted against. It's what CAR-Ts are targeted against. Okay, so leaving that induction, should we stick with transplantation? And you've seen all this, so I'm going to skip through it. This was the evidence that showed transplant was better than conventional treatment. These are two studies that, again, go back and compare RVD to a transplant. Both showed that the transplant was better. So if you can tolerate it, a transplant looks good, but you shouldn't push the envelope with transplants because there's a mortality associated with it. And above the age of 70, I think the balance shifts more now to using novel agents than it does to high-dose chemotherapy. I think that's arguable, and it depends on how fit the person is. But I think it's a place where you can really start to question transplant, no transplant. And the reason I say that is because we did a study, and the patients that were of the age group that could have got a transplant, who didn't, did worse than the patients who received the transplant. Not everybody is pursuing this consolidation, more chemo after the transplant when you've recovered and you're strong enough again to have something. But down the right-hand side or the left-hand side, you can see some of the agents that have been used, and all of them seem to increase the response rate. So as you're going through treatment, you're reducing the number of cells, the number of bad cells, and allowing the good cells in the immune system to control the cancer long term. And even for some patients, a double or a tandem stem cell transplant has some merit. And this is going back to an old French study where you can see the impact of these things, not in the first 5 years, but on the 10-year survival rate. So this is one of the major lessons of the last 5 years, and that is, if you see those little dots, those are the bad cells, the intraclonal variation in the cancer cells, and then you're applying treatment as a selective pressure. And so in the bone marrow, after a transplant, you've got some cells that have got better behavior that may lead to late relapse, and you've got some that are really behaving badly, and you need to control those badly behaving cells to prevent early relapse. And so maintenance seems to do that. Chemotherapy simply doesn't work as maintenance. The drug lenalidomide clearly works by its immune effect and works in the maintenance setting. And here's a study which compared patients who had maintenance to those who didn't. And I've never seen a survival curve for PFS that's as different as that. I mean, it's staggeringly different. And more, another maintenance study will be presented in ASH using the drug ixazomib. I would expect an impact as well on outcomes. So now we have potentially 2 drugs that are going to be beneficial in the long-term exposure treatment maintenance setting. I'm going to skip all of this evidence. If you do a meta-analysis, put everybody's data together, you can see, again, that when you get out to 90 months, you start to see the curves separating, pushing long-term survival and cure fraction up. And it goes for people with all types of disease, young, old, post-transplant, those who didn't receive a transplant. So prolonged exposure is one of the important features of disease. But the thing that we struggle with, and patients struggle with, is how long is long, and how do you rationalize leaving somebody on a drug for many, many years, maybe even 5 years or beyond. So there's a limit to what patients like yourself would want to go through. And so you can use the concept of MRD monitoring as a way of deciding when a patient has had enough, when you've achieved the maximum response, and then you can use it to detect relapse early. So what will happen is people will take 2 or 3 years, maybe as arbitrary time points. You'll stop the maintenance, and then there'll be very important and frequent disease monitoring. The disease, unfortunately, comes back. And I think when it comes back, there's a temptation to think that you're doomed. And I think that is so not the case. And you have to think of the flavors of relapse, which can be slow, kind of just the M spike going up, no clinical symptoms. It's pretty easy to manage that. If you're on maintenance, you can just meddle with the doses a little. You get people back into a stable phase, then stop. If you have full-on aggressive relapse, then you need to switch to something else. But the important thing to say is that a lot of people respond. People do well at relapse. And even if you've had 2 relapses, there is still very strong potential that you can pick from those agents we have good combinations that will get people back into an excellent response. These are the sort of things that patients and doctors need to consider at relapse. What are the disease-related factors that are going on? Did they get side effects from the first lot of treatment they had? And how is their general health? And these are all very important to personalizing your treatment decisions. And so I'm going to stop there and finish with this modification, I think, of that slide that Leif showed you about clonal tiding. And the important thing is, because we understand this intraclonal variation, if you were resistant to a treatment before, people thought you could never have it again. But this theory would say it's always worth trying something because the sensitivity of the disease can change over time. So I'll finish there. Thank you for your attention.